This table comes directly from the Lewis text, Table 45-2, and it points out some of the gerontological differences in the assessment of renal and bladder function. I encourage you to pay close attention to some of these details. It's very important for the registered nurse to be able to recognize the normal variations in OA assessment findings in both renal and bladder function. Here is a sample exam question. When assessing renal and urologic functioning in a 75-year-old female patient, the nurse expects to find which of the following normal age-related changes. Select all that apply. Please feel free to pause and answer the question. The correct answers are A and C. The decreased estrogen levels in the female older adult population results in thinning and drying of vaginal tissue. And the answer C, below normal specific gravity value, is correct. The kidneys lose their ability to concentrate urine as the individual ages. E would be correct if it read decreased creatinine clearance, increased BUN, and increased serum creatinine. Okay, let's see how well you can identify whether these statements are facts or myths. Incontinence is normal and not worth reporting to the healthcare provider. Myth. Urinary incontinence is a common geriatric syndrome. Fact. Urinary incontinence has physical, psychological, and economical consequences. Very much a fact. Nurses are in a key position to identify and treat urinary incontinence in hospitalized OAs. Absolutely. Anything that interferes with bladder or urethral sphincter control can result in urinary incontinence. Fact. So we see here some common things that result in urinary incontinence in the older adult. They would include confusion, depression, infection, urinary retention, restricted mobility, fecal impaction, and medications. Moving on. Acute incontinence is typically transient. It's characterized by a sudden onset. It's generally associated with some medical or surgical condition, and it is usually resolved when the underlying cause is corrected. So it's important for us as nurses to do our best to understand and identify what that underlying cause is so we can correct it. Gotta take a look at those medicines. They're a common cause of incontinence, and they should always be suspected as a potential cause of any new incontinence. And there's some classifications of meds that might typically be associated with urinary incontinence of the acute type. Here's an acronym, toileted, each of the letters standing for a specific potential contributor to incontinence in our older adults. The information is in your reading, and I'm not going to go through each and every one of them, but I would encourage you to familiarize yourselves with what the terms stand for and how they might be applied to your assessment of the older adult population that is experiencing incontinence. Here's a sample exam question again. When managing the care of a hospitalized older adult who is incontinent of urine and experiencing acute confusion, the nurse best addresses the OA's urinary incontinence by doing what? Take a minute to answer that. The answer is actually assist the OA to the bathroom every 2 hours. We want to avoid indwelling catheters because of their increased risk for urinary tract infections. We know that incontinent briefs increase the risk of skin breakdown, and we want to maintain adequate hydration unless contraindicated. Remember that older adults do in fact have a reduced thirst reflex and tend to become dehydrated quite easily. Chronic incontinence refers to urinary incontinence that is persistent over time. It is not related to an acute illness. It continues over time and it often becomes worse. We're going to distinguish between several different types of urinary incontinence because Understanding the particular type of incontinence your patient is experiencing will help you implement the most appropriate interventions to help that individual manage that incontinence in the best manner. The first one is stress incontinence. This is commonly seen in older women who involuntarily lose their urine as a result of a sudden increase in intra-abdominal pressure, which is usually a result of coughing, sneezing, laughing, lifting something, and strenuous exercise. The leakage is usually in small amounts and it may not occur on a daily basis. It's very unusual in men and it mainly occurs after urethral surgery or treatment for BPH or prostate cancer. I'll stress again that stress incontinence is typically related with an increase in intra-abdominal pressure, usually a result of coughing, sneezing, laughing, lifting, and exercise. Treatment for stress incontinence, the best treatment is teaching the patient how to perform Kegel exercises. This is known to be best practice. Other interventions may include encouraging the patient to have weight loss, smoking cessation. Smoking leads to chronic coughing, which can actually precipitate the incontinence. The application of topical estrogen products, and the use of pessaries. Pessaries are devices that can be inserted into the vagina that will help reduce urinary leakage caused by stress incontinence by applying pressure to kind of close off the sphincter temporarily while the pessary is in place. Here are examples of two types of devices to assist the male patient who has some stress incontinence. One would be a condom catheter, it's applied externally, and the other is a penile compression device, which is a mechanical device that's applied to the tip of the penis to prevent any flow or leakage via the urethra. People who are struck by a need to urinate but can't reach the toilet in time may have urge incontinence. They typically have a sudden urge to urinate that might be triggered by something like the sound of running water or a dripping sink, something like that. With this type of incontinence, there's typically a large amount of urine that is leaked, and the individuals may find themselves running to the bathroom with this sudden urge to go, even if their bladder is mostly empty. It's usually associated with an overactive detrusor contractions, and the detrusor muscles are the smooth muscles of the bladder, and is typically caused by genitourinary conditions such as cystitis, urethritis, tumors, stones, etc. It may also be associated with CNS disorders such as stroke and Alzheimer's disease, dementia, and even Parkinson's disease. Again, leakage is periodic but frequent, and the amount of urine that is leaked is usually large. Treatment for urge incontinence, typically behavioral interventions such as bladder retraining. There may be urge suppression strategies such as distraction, relaxation, the avoidance of dietary irritants such as caffeine. Anticholinergic medications can also be used to relax the bladder muscles that are overactive and are precipitating this type of incontinence. But you want to make sure that you educate your patient that side effects may include dry mouth, dry eyes, constipation, blurred vision, and perhaps even sleepiness. Oxybutynin and Detrol LA are a couple of common anticholinergics that you might see patients on for the control of urge incontinence. Overflow incontinence often occurs as a result of an atonic bladder that does not contract adequately. Some causes of this would include diabetic neuropathies or spinal cord injury. There could also be a mechanical obstruction that's preventing the bladder from emptying fully, for example, an enlarged prostate. In this situation, the bladder is chronically full, and this increases the bladder pressure to a higher level than the urethra can withstand, and it causes the involuntary loss of urine. Patients with overflow incontinence complain of frequent loss of very small volumes of urine. Treatment of overflow incontinence involves urinary catheterization to decompress the bladder. It's typically done as a it's typically not an indwelling catheter, but rather an intermittent catheterization. It's used very frequently with patients who have neurogenic bladders as a result of spinal cord injuries or other chronic uh, neurological problems. What we do in the home setting, if the individual is managing this themselves at home, is we teach our patients how to do so under clean or aseptic conditions. Whereas in the hospital, we would still certainly perform this intermittent catheterization procedure using sterile technique. In the home, it's a clean procedure. Patients are taught to clean the catheter um, in between catheterizations, and they typically will use that same catheter several times over a period of 7 days before changing it. And this is considered standard practice for home health care. We could also teach our patients the Crede maneuver. If you observe the diagram, the individual is standing over a toilet or sitting on a commode, leaning forward, pushing inward and down on top of the bladder, actually trying to help further express the urine from the bladder. It's an application of non-forceful, smooth, even downward pressure, and that can stimulate the voiding reflex. Functional incontinence is yet another type of incontinence important for the nurse to be able to distinguish based upon symptoms in the situation. Functional incontinence is caused by non-GU genitourinary factors. It is the involuntary loss of urine as a result of either the inability or the unwillingness of the individual to toilet appropriately, and can be caused by physical, mental, psychological, or environmental factors. Environmental factors are very, very important to think about in terms of helping patients deal with functional incontinence. And your hospital setting is a great example. Think about how quickly somebody might need to go to the bathroom. They put their call light on, 5 minutes go by if they're lucky. Then by the time we get there, we've got to manage their IV pole, get them out of bed, and it's difficult because they've had surgery and they've got to walk to the bathroom, and we've got all these electric cords that are in the way. And guess what? We didn't get, we weren't able to get them to the bathroom in time, and they have an accident. So that is considered functional incontinence. So clients with physical disabilities affecting their gait might have trouble getting to the bathroom in time. So what would you do? Instead, you might choose to place a bedside commode near the patient's bed to prevent them from having episodes of functional incontinence. It would also help decrease the risk for falls. Important for us to know that most of the time, most of our older adults have some type of mixed incontinence, a combination of two or more of the types of specific incontinence that we have been talking about. How do you diagnose urinary incontinence and the type? Bladder diaries are very useful. Also, we can do a basic evaluation doing a history and physical exam, and testing for post-void residual can be very useful as well, using a bladder scanner. And if you have the opportunity in the clinical setting to use a bladder scanner and you haven't yet, I encourage you to do so. You don't need an order for it. It's not an invasive procedure. Have your patient void and and if they think they're finished voiding, then go ahead and use the scanner to measure the amount of urine that remains in their bladder. And that is what's called a post-void residual. The normal post-void residual is anywhere between 50 and 75 milliliters. If you consistently measure 200 milliliters or more post-void residual, there's need for further evaluation. Something's going on that needs to be further evaluated because that individual is not emptying their bladder adequately. In addition to a diary, to bladder scanning, to a history and physical, maybe a urine analysis, you also might want to conduct tests of provocation while the client has a full bladder. While the client has a full bladder, you ask them to cough, you ask them to stand, you want to note any involuntary urine loss. If they're able to, you want to have them bounce on their heels or their toes a couple of times. See if they're able to retain their bladder. Again, just very useful screening tools to help us try to determine what's going on with them in terms of their incontinence. Indwelling Foleys are a major source of urinary tract infections, and we have extremely reduced the frequency with which we utilize Foley catheters in the hospital setting. And we've seen a tremendous, wonderful decrease in the amount of secondary urinary tract infections as a result of Foleys. Despite that, there are some times when a Foley catheter is appropriate, and the benefits to risk ratio outweigh the risks. But if you are female, if you are older adult, if you're going to have that Foley in for a significant period of time, if you have diabetes, and if you are suffering from renal insufficiency, your risk of developing a UTI while having a Foley catheter is increased. The Foley catheter bundle is an evidence-based standard of care that we implement whenever anyone does have a Foley catheter. I encourage you to read through this. This information is testable, and of course, in the clinical setting, I would certainly hope that you're practicing this with scrupulous attention. Here is a list of some appropriate indications for the use of an indwelling Foley catheter. This is not new material. I encourage you just to read through it and familiarize yourself with it. It also is testable material.